There we go. Okay, I'm going to be very brief. My name is Allan O'Dette. I'm the CEO of the Ontario Medical Association. It's really a privilege for me to be here this morning. We're going to have a couple of guests come up and speak. And it may be Franz that I'm going to call on you to begin with, because I know you have to exit the room. We're really here at Queen's Park today trying to highlight some very near, mid, and long-term strategies so that we can help physicians, help our families, our neighbors, and our communities. We're here highlighting a couple of key areas that we think we ought to focus on in the very near term. Trying to recruit more foreign-trained physicians, bring some urgency with earnest to palliative care, and think differently about how we might reduce the backlog of services and wait times in the province. So we're going to introduce a couple of people before we go to our esteemed panel on the left and right of me. And I'm going to call on Franz Gelinas first to come and say a few words, Franz, to our guest today. Franz needs no introductions. He's the health critic for the New Democratic Party. And I am going to say a very big friend to the doctors of Ontario. You've been an incredible advocate for physicians. We've been an incredible advocate for patients and the people of Ontario. And for that, I'd like to say thank you.
Good afternoon, everyone. Bonjour tout le monde. Annie. As it was mentioned, my name is Franz Gelinas. I'm the MPP for Nickel Belt, a great big riding in northeastern Ontario. And for the last 15 years, I have been the health critic for my party, the NDP. I am so in awe of all the work that you have done. Physicians always worked hard, but the last 2.5 years have been especially hard on each and every one of you. But you were there, you answered the call, you looked, you cared for us, and we appreciate everything that you have done. I see that you have a few asks. The first one, do we need more family physicians? Do we need more physicians throughout Ontario? Absolutely. In Northern Ontario, you put out a report that showed that we were short 350 physicians just for my area. And in Nickel Belt, it's 40% of the people that don't have access to primary care. They don't have a family physician, they don't have a nurse practitioner. This has to change. And then we all know that we are in 2022, and yet there is no well-functioning electronic medical system record. Like, how could that be that when you connect with the health unit, when you try to get vaccination rate, when you try to connect with the lab reports, how could it be the government has a role to play to make sure that we have an EMR that actually works, that actually connects all of you so that you don't spend 2 hours on your computer for every hour you spend looking after us. This has to be fixed. Care in the community. I'm a big fan of care in the community. I really believe that care should be as close to people as can be, but I also believe that it has to be not for profit. You will see I will be putting forward a bill. The idea is really we have this system called Medicare where care is based on your needs. If you see a physician, you don't have to pay. They get paid through OHIP. I want this to absolutely continue, but I don't want any barriers to access to come through privatizations, and we have seen this happen. I'm so pleased to see that right there in your leave behind, you talk about the importance of integrated community care in the not-for-profit sector. I thank you for that. And the last part is palliative care. This morning, again, I asked questions about Bill 7. Bill 7 that takes away the rights of frail elderly patients to consent. The right to consent is something that you've all learned. We've all learned from our first day in university that you don't do anything to a patient without their consent. But if you are frail elderly in Ontario, we've taken that right away from you. Same thing, the right to keep your health information private. We all know that it's a big responsibility on each and every one of you. Anybody who runs an office, you spend an awful lot of time making sure that personal information, personal health information is kept private. Yet, we have a government that has taken that right away from frail elderly patients. And now we know, through the good work that you have done, that close to 40% of alternate level of care, ALC patients, are actually palliative care patients. They are people who would be way better served out of our hospital, but into a palliative care setting. And here again, the government has a role to play to make sure that we build those 1,000 new beds in palliative care so they are accessible and available to everybody who needs it. I know that you will continue to work hard. As physician, you speak from a place of power. People admire you, people respect you, people depend on you. So I encourage you to continue to push those ideas forward, to continue to be loud. Don't be afraid to push all the good work that OMA has done to try to improve our healthcare system. It will make a difference. The recruitment of internationally trained. We know that other provinces go through this process way faster than we do. Why is it that we have right here, right now in Ontario, many physicians that would have the qualifications to look after us, to start working in our healthcare system, and yet it will take them years before they are able to do this. Certainly funding more residency spots, funding more opportunities for them to show that they have the knowledge, the skills to meet the very high bar that is set for every one of you to join the College of Physician and Surgeon. We have to do that faster. We can do this faster. So again, thank you for everything that you do. Thank you for the hard work that you've put in for the last 2.5 years through the pandemic. It is appreciated. We could not have made it through without all of your efforts. If I can be helpful, if I can be useful, I'm there for you. I will support you. Ça me fait toujours plaisir de rencontrer les membres de l'Association des médecins de l'Ontario. Si je peux vous aider d'une quelconque façon, ça va toujours me faire plaisir. Thank you for coming to Queen's Park. Merci. Chemewich.
Got my mask caught up in my glasses. Franz, thank you. And again, for your public service. We really often don't take time enough, whether you're government and carrying the load of a minister or doing the advocacy work that you are in opposition. Thank you. And we really mean that to the men and women who serve all of us. So thank you, Franz. It is really our intent to strengthen the ties that bind with government, and many of you will recognize that we're focused on 3 really key priorities that have been repeated twice now, but it's really the part of the foundational piece, a prescription for Ontario. It's a doctor's 5-point plan that we went out round about a year ago to over 10,000 Ontarians. We went out to several thousand physicians. We went out to about 120 other associations, from business associations, nursing groups, pharmacy, literally 120 some other groups and associations. So the prescription for Ontario is really a consensus document on what Ontarians, physicians, and association groups think is important. And we've just taken advantage of our ability to convene, and we'll lead, drive, and shape those priorities, working collaboratively with the government. The government is listening to us. The government shares our goals and objectives, and that is to improve access to health care for our families, for our neighbors and our communities. And I believe that, and I believe that they are listening and doing their level best to work collaboratively with physicians as they are with many, many other groups. And with that, I'm going to invite the Minister of Health to make some brief comments. And Minister, welcome you. Thank you.
I think it's afternoon. Good afternoon, everyone. Sorry I was a few minutes late. The media had a couple of questions for me. So I want to welcome you to Queen's Park. I believe very strongly that these advocacy days are a really important tool. And it's not a one-way conversation. It's a back and forth. It's hearing feedback, but it's also receiving input and feedback from your elected officials. May I start with a thank you? There are actually two thank yous. The first is, as France mentioned, unprecedented, what we are experiencing in the province of Ontario in terms of first a pandemic with no vaccines, then a pandemic with a vaccine, then we're dealing with a substantial surge in Ontario with viruses. So thank you for your work that all of you are doing in community. The other thank you is a thank you to the OMA. I don't think that we say this enough. This physician service agreement is the first one since 2012 that was able to be successfully negotiated without arbitration. Absolutely. And it is because, exactly as Allan said, we work together. When you have common goals, then we can find common solutions. And I'm very proud of the fact that my predecessor, Christine Elliott, and the OMA were able to successfully negotiate that, and we're about to see the fruits of the labors on December 1st. So thank you for being committed to seeing how we can improve care in the province of Ontario. I have, as I was listening to France, and actually she and I got elected in the same year, so we've spent a lot of time both in opposition benches and talking policy and ideas. And when reference is made to increased residency spots, check, we're working, we've done that. Postgraduate spots, check, we've done that. We've had that expansion. I cannot remember the last time a minister did a ministerial letter to say, colleges, you have to expedite these reviews, and when appropriate, give those licensures when appropriate. So all of these pieces together, Bill 7, another example of we saw the issue of alternative level of care patients. We needed those beds for acute patients. What can we do collectively to make sure that those individuals are properly served in community? We will continue to do that work. I know that your board is very engaged to make sure that that work gets done. And I want to continue those idea sharings and those opportunities, because at the end of the day, it is your members and you who are going to implement and make change in our community. We can have policy initiatives, we can pass legislation, but it is you on the ground in front of your patients that will make the true difference. So thank you for your advocacy today, and happy to have the conversation continue. Unfortunately, I cannot stay for the entire roundtable, but I have asked a member of my staff to make sure that they are noting and sharing those ideas back with me. Stay well, everyone.
Thank you, Minister. Pardon? Okay. So we're going to go to the panel? Okay. Minister, thank you very much for taking time. We'll let you exit out the back of the room. Thank you so much for all that you do and your support for being here this morning. Okay, we had a couple of other guests that were, I believe, en route, but we're going to move forward with our panel, and I'm going to invite Dr. Folds. I don't see Dr. Folds anywhere in the room, but, oh, she's right here. This is the illustrious chair of our board, amazing palliative care doctor from London. I am going to introduce you because I'm very proud of you. has a long history working in medical politics, and the leadership that Dr. Folds brings to the OMA has been pretty amazing in the last year or so, and she's a steady rock and force for me and for her patients. She does this work of chairing a board essentially 7 days a week while working on First Nations and Aboriginal communities, making house calls, driving all around Southwest Ontario, and I want to say thank you while we have an opportunity here. And so Dr. Folds is going to introduce our panel.
Thanks, Alan. Thank you. I just want to welcome and thank everyone for attending the lunchtime panel on behalf of the OMA. We want to take a deeper dive into the problems and the solutions that we're presenting today at Queen's Park. All of you in the room know that we have a 5-point plan, and that's very rich, and Alan has described how that 5-point plan has come to fruition. But this panel today we've assembled is going to really focus on the 3 key themes that we know that we can make traction and we can make tangible change to. That's the integrated ambulatory care centers, the health human resource issues, and palliative care. And on stage, we're very fortunate to have these physicians bringing their experiences and knowledge to the issues that we are advocating for. And we want to really work with the government to improve access to care and to strengthen our system care delivery. Each panelist is going to present, and following that presentation, we'll have about 10 minutes for a question and answer from you in the audience. So let's get started. I'm going to introduce our panelists. Dr. Rose Zacharias, our president, is a family physician with a hospitalist-based practice. For the past 20 years, she's practiced as an emergency department physician, hospitalist, and surgical assistant, primarily in Aurelia Soldiers Memorial Hospital. She currently provides medical coverage to psychiatry inpatients at Waypoint Center for Mental Health in Penetanguishene. Dr. Zacharias has been a member of the Ontario Medical Association Board as a director since 2020. And she's really known as a conversation catalyst. If those of you who haven't spoken with Rose get an opportunity, I think you will be really impressed, not only with her style, but her authentic leadership. We're beyond fortunate to have her as our president of the OMA, advocating for issues both to our members and to government here. Dr. David Urbach is head of the Department of Surgery and director of the perioperative services at Women's College Hospital and professor of surgery and health policy management and evaluation at the University of Toronto. Through his leadership, the Department of Surgery at Women's College Hospital has become recognized for surgical service innovation. And an example includes the same-day discharge for total joint replacement, virtual post-operative care monitoring, and single-entry referral models for surgical services. Dr. Cathy Mastrogiacomo is a comprehensive family physician practicing for the past 32 years. She's the current chair of the Ontario Medical Association section on general and family practice, where her primary goal is advocating every day, and talk about a 7-day-a-week job, for family physicians and their day-to-day practice needs. Her other leadership role is on her local Ontario health team, where she is the co-chair of the Scarborough Family Physicians Network. And last but never least is Dr. Stephen Singh. Dr. Singh is a family physician and a palliative care specialist in Brantford. He is the chair of the OMA section on palliative medicine. He has served as a director at large at the Canadian Society of Palliative Care Physicians. He's represented Ontario on the Palliative Care Program Committee at the College of Family Physicians of Canada, and he served the college's peer review committee for certificates of added competency. Each of these physicians will share their perspective on integrated ambulatory care, health human resources, and palliative care. And I'd like to start with Dr. David Urbach to share his perspectives on IACs.
Thank you. Is the microphone working? Yep. It is? Okay, great. So I'm going to talk a little bit about IACs, Integrated Ambulatory Centers. Public hospitals are great. They're the backbone of the health system. They do a lot of really critical and important things, but they don't do everything perfectly or as well as they could. And that there are areas for improving a lot of the very routine services that we provide, particularly common surgeries, low risk, low acuity surgeries. And it would be very helpful to have some sort of capacity to provide those types of surgeries that wasn't so reliant on the public hospitals. The solution that's been proposed are integrated ambulatory centers. And I think the integrated part is a critical part, because whatever these ambulatory centers end up looking like, they really have to be closely integrated with the rest of the health system, the regions, and that includes the public hospitals. Because ultimately, we're all the same people, we're the same physicians, we're the same nurses, same system leaders, and we all have to make sure we work together and make the most of the resources that we have. So why do IACs work, and how can they possibly be an improvement for the current problem, which is a large backlog of surgical services that we've accumulated from the pandemic, but also really pre-existed the pandemic. We've never really had the supply-demand equation right. We've always had issues with access. IACs, or any type of specialized focus factory, can address the problem in two ways. The first is through standardization, specialization, and creating the efficiencies that happen when a facility really focuses and creates excellence in one very specialized and unique type of care. An example that a lot of people are familiar with is the Shouldice Hospital, that has an international reputation for hernia surgery. I'm a general surgeon. I do hernia surgery. We general surgeons don't exactly do what the Shouldice Hospital does, but the fact that it does what it does so well and so efficiently means there's a lot that we can learn from that type of model. The other things that other types of facilities can do is they can be somewhat insulated from hospitals, which are very susceptible to system shocks. We saw a huge example of that, obviously, with the pandemic, which was a wholesale closure of a lot of our ability to do elective surgery for months at a time. But that's just a big system shock. We get these shocks all the time. So when hospitals are overloaded, when there's a bed crisis, when there's too many ALC patients, when emergency departments are overloaded, often the pop-off valve is scheduled elective services, and very often it's surgical services. I've been working as a surgeon since 2001, and we've in Toronto, we've constantly had to cancel elective scheduled cases just because of these smaller disturbances that occur on a daily basis. So if you can create some sort of entity that's less susceptible to those types of system shocks and stresses, what we can do then is preserve our ability to provide elective services regardless of what's going on in the rest of the system. What happened a lot during the pandemic is we often had a choice, which seemed to me at times to be a false choice, which was we could either do surgical procedures, or we could just reallocate all of our resources and get set up for the possibility that the system would be overwhelmed with floods of viral illness, with COVID or whatever. But it really is a bit of a false choice that we were provided, because we can actually do both as long as we appropriately structure the different environments where we provide care, so we don't have to be so dependent on hospitals, which, as we've seen, are very vulnerable to these types of widespread system disturbances. So the final thing I will say about IACs and facilities is they're also only one part of addressing the issue of wait times for surgery and backlog. I often talk about this problem as supply and demand. So the supply is how much surgery can we deliver in hospitals and elsewhere. The demand are what's the need for patients who require these types of services. But in the middle, there's coordination. And right now, we're not doing all that much about coordinating and matching the supply to the demand. And there's an enormous amount that we can do, even within the resources we currently have, through things like single entry models, central intake, centralized triage systems, where we can really, while we're building up a capacity and supply, we can do a lot better and reduce wait times and enhance access with the resources that we currently have. Thanks.
Thank you, Dr. Urbach. I can see how the IACs are really going to be important to allow our system to treat more patients. I'd like to move on to Dr. Mastrogiacomo. She's going to talk with us about the health human resource issues as it pertains to family practice.
Thank you, everyone, and thank you for the members of Parliament that are here in the room and to my physician colleagues. So today I'm going to be talking about the problem of doctor shortages, and particularly family doctors. So family medicine is on life support. So that's a huge problem right now, and it's I think we can address it in two ways: increasing resources and decreasing the demand. So we know that family doctors are the backbone of our healthcare system. Right now, there's an exodus of family doctors from comprehensive office-based practice. 75% of physicians surveyed by the OMA have experienced some level of burnout, and that's up from 66% from the year before. So let's dive a little bit deeper into that problem. We know that 1 million Ontarians don't have a family doctor, and we believe that every Ontarian deserves access to a family doctor. Our data shows that 40% of Ontario doctors are thinking of retiring early. That includes me. Doctors are cutting back their practices and not taking on new patients. For every 1 hour of patient-facing care, we're spending 1 to 1.5 hours of work on paperwork that's done after hours, and that includes nights and weekends. So what do we do about this? The one thing that I want to tell everybody, and that I tell my colleagues here, that I have a day job and I have a night job. And so when patients come to me at the end of their visit and they say, "Oh, doctor, I hope you're going home tonight to rest," I turn my screen to them and I show them at the bottom of my EMR the 150 messages that I have at the end of my screen, and I say, "No, I don't go home to rest. I go home and do that every night," and that's causing my burnout. So the exodus of family doctors is leading to longer wait times in the ER. We know that ERs are backlogged. Some ERs are actually closing, and that's due to the burnout that family doctors are feeling today. So what are our solutions? I think of this as a two-pronged solution. We need to increase the supply and decrease the demand on doctors. Ontario doctors are recommending an immediate increase in the number of both family medicine and specialist residency positions for international medical graduates. Let's develop practice-ready programs for a quicker route to determine whether international medical graduates are ready to work in our communities where care is needed, like in the North. We know that 7 other provinces have these practice-ready programs, and I think Ontario should move up and do this as well. But I think that these are long-term solutions. They're solutions, but they are long-term. They're going to take about 5 to 10 years to reach fruition. We need some short-term solution for the doctors that are practicing right now, doctors that are burning out, doctors like my colleagues here in this room. So what would that look like? We need to have more investment in office infrastructure and team-based care. Funding is needed for doctors to hire nurses, physician assistants, scribes, things that will help us in our day-to-day practices. Let me practice to the top of my scope. Each day I'm taking out staples, ear syringing, doing B12 shots and allergy shots. Those are things that nurses can help us with. So we need help so that we can practice the top of our scope and do the things that we need to do as physicians. Allow us to have some proxy billing to hire physician assistants. So if they could see some of the less complex cases, I could practice to my scope and see the more complex cases and take on new patients. If they were helping me in my practice, I could take on a new patient because right now I'm burnt out and I can't take on new patients. Let's connect all doctors to a team of allied health professionals and a team of doctors that can help us cross-cover when we need to take holiday or we're sick or we're even having babies. Right now, there is a locum problem across the province. Doctors can't leave their practice because there are no locums to cover us. So that's one solution. The next solution is streamlining our computer systems. Let them all talk to each other so that I don't need to log in to multiple sites each day. I need to make a referral to sick kids. I need a different login. To log in to do a virtual visit with OTN, that's a different login. If I want to refer a patient to bariatric surgery, another login. Different passwords, different platforms. I need 2 computer screens at all times so that I can transport information from one screen to the other. Let's make it easier so that from my EMR, I can make a referral nice and simple. Let's think about getting a universal, provincially funded EMR. Wouldn't that be wonderful? I think we need that so that all systems can talk to each other. I can talk to the hospital, I can talk to the pharmacist, and I can make these referrals faster. Then we talk about paperwork and forms, the bane of my existence. And that's what I said earlier. I have a night job and a day job. At night, I do all my forms, all my referrals. We need help to decrease that so that I can see my patients and take on a new patient if I wasn't so burnt out. So what I think is the joy of my practice is when I have that patient right in front of me and I feel that I'm part of their health journey. Right now, I've lost the joy in practice because when I go home at night, I'm burnt out doing my night job. Let's look at some solutions so that the government can take some forms away from us. Wheel-trans forms, audiology forms, hearing aid forms, City of Toronto housing forms. Why is it that I'm the one that's deciding if a patient needs a 2-bedroom apartment or a 1-bedroom apartment? I think somebody else can do those kind of forms. Let the doctor go back to being a doctor. Sometimes I feel like I'm, just doing paperwork all the time instead of doing the things that I was trained to do the best. So let's work on systems where the forms are either made easier right from our EMR or that somebody else is completing some of these forms for us. And finally, let's look at the referral process system for family doctors. Let's consider a centralized referral process with a next available appointment. How many of us here in the room are getting rejections to our referrals day in and day out? That's leading to our burnout because we're looking after more complex patients for longer, older patients that can't get the care that they need. We need a quicker referral system that works for our patients. I practice in Scarborough, but I have patients that come to me from Brampton, Woodbridge, Durham, wherever. We all have that in our practice. I shouldn't have to go on Facebook or WhatsApp to find a doctor in a different community for my patient. We need to make the system easier for our patients and for us. So let me just summarize the main points. It's a supply and demand situation. Let's increase the resources with more family doctors, allowing foreign-trained doctors to practice faster, but let's keep the doctors that are in practice, people like me and you, in practice longer without having to think about retiring early. Let's decrease the demand on family doctors by decreasing their after-hour paperwork and the forms that we complete. Let's provide us with well-functioning team-based care with nurses, physician assistants, and scribes to help us so that we can practice to the top of our scope. Let doctors go back to being doctors again. Let us find the joy in medicine again. Thank you.
Thank you so much, Dr. Mastrogiacomo. I think that very eloquent summary at the end of 5 or 6 very key focused things that we can do to bring the joy back in practicing medicine and improve your efficiency, to improve access to patients in Ontario is key. Thank you. I want to turn to Dr. Singh. Dr. Singh is going to talk with us about palliative care.
Thank you, Cathy. So first of all, there are many misconceptions of what palliative care is. Palliative care really is a focus on comfort and symptom management for anyone with a life-limiting condition. It's not limited to the last few months of life or last few days of life, and certainly it can coexist with other life-prolonging measures. Unfortunately, 40% of Ontarians died with no access to palliative care in their last year of life. This is completely unacceptable. Palliative care, unfortunately, in Ontario is a postal code lottery. Where you live in Ontario really determines the availability of palliative care for yourself and for your loved ones. And it's really a lack of access to palliative care that's directly contributing to the ALC, or alternate level of care, crisis that's currently going on in hospitals. I'll give you an example. One of our family friends has a father, we'll call him Bob. He has advanced dementia. He recently had a heart attack, ended up in hospital, ended up in the ICU, eventually made it to the hospital ward. His goals changed from life-prolonging therapies to more of comfort alone, but unfortunately, he's in this in-between place. His life expectancy is likely greater than 3 months, so he doesn't qualify for traditional residential hospice or palliative care unit, which are usually the palliative care beds in the hospital. That's what they're called. The resources for home care and palliative care in the community don't exist in his region to the level that he requires. And the wait time for long-term care currently in his region is greater than 1 year. So he's among the 6,000 patients in Ontario designated ALC, alternate level of care, that are essentially just stuck in hospital with nowhere to go. This, again, is completely unacceptable. These folks do not need to be in hospital. A day in acute care costs about $1,100 per day. If you compare this with hospice-style care, that's about $400 a day. So if we take a look at the amount of money that we would have invested in these patients, especially towards the end of life, in the acute care setting, and transition those funds to other settings where palliation can be provided, as per the Auditor General of Ontario's numbers, we would actually be saving $161 million per year. So it's not increased cost that we're talking about when we're talking about palliative care investment. It's actually a cost savings of $161 million per year. So essentially, it's a no-brainer. So what do we at the OMA recommend? Palliative care really needs to be universal, it needs to be equitable, it needs to be around the clock, and it needs to be very high quality. Many patients prefer to be at home as they age. This, of course, is the least expensive for the system and is what people prefer to have happen. So in order to make this happen, we need to ensure that home care models and home care staff are properly funded and properly trained as well. In addition, we need funding for physicians to be on call 24 hours a day to help manage these patients at home. Only recently, after years of the funding being frozen, was the funding applications for the funding reopened. But even still, it needs to be reopened more equitably than it currently is being done. In addition, training needs to be in place to ensure that all physicians and all allied health have at least the basics of palliative care, because after all, palliative care is everyone's responsibility, not just the responsibility of palliative care specialists. For Ontario's population needs, we need about 1,000 more hospice and palliative care unit beds than we currently have throughout the province. These need to be targeted to the areas of the province where the highest burden of ALC is, and we already have this data, so we are able to target that if we have the funds. One of the barriers that we currently experience is that hospice beds currently are about 50% government funded and 50% community fundraising, which means that only the more affluent areas of the province can really have access to residential hospices. In addition, not all hospice beds need to be located in their own structures. We already have long-term care facilities, many of which can be restructured in such a fashion to provide a hospice-like atmosphere, a hospice-like environment for a certain segment of their patients. This would especially be true for the patients with greater than 3 months of life remaining, so they would not ordinarily qualify for a traditional residential hospice or palliative care unit, but perhaps less than 1 year of life. Right now, there's nowhere for these patients to be other than being an ALC patient in the hospital, so this would be a major cost savings. The ultimate goal would be to ensure that there is an around-the-clock system in place to allow patients to receive the right care in the right place at the right time. Thank you.
Thank you so much, Dr. Singh. I love how you say right patient, right care, right time. And I think aligning goals of care to the patient and being able to provide that a place of care and that type of care is so critical. Not only is it a cost savings, but it's just a quality of life issue. We are all going to die, and we all want to be able to do it where and how it matches our goals of care. So thank you. Last but not least again is Dr. Zacharias, who's going to talk and give us wisdom about all three of these very focused solutions from the Ontario Medical Association.
Thank you. Thank you so much, Cathy. And it's really wonderful to be here. I'm going to keep my remarks brief because we've had a packed agenda and we've got some place to be even in the next little while posing for a photo out there on the grand staircase. So we're excited about that. For those of you who are in the room and who welcomed us as physicians to Queen's Park today, I want to say thank you very much for the warm welcome. We sat in a question period and we felt very welcomed. So thank you so much for that. Absolutely. And for my esteemed colleagues in the room who have come away from their patients and their practices today and prioritized expressing our commitment to working with government on the solutions that we believe will make a difference in the time of healthcare system crisis, I want to thank you as well for taking the time away from your patients to come here to Queen's Park today. And it really is that. It really is that. This is a demonstration of our genuine, deeply felt commitment to our patients, because it's what we do day in and day out as doctors, is we care for our patients. And even prior to the pandemic, we know there were gaps in the healthcare system crisis. And I think that the likes of a physician who is a resilient, high capacity, compassionate professional has actually absorbed a lot of the shortcomings over time inside the healthcare system, because at the end of every day, we're committed to our patients. And then there was the pandemic, and those gaps became chasms, and still we go to work every day caring for our patients. And we will go to great lengths to make sure our patients get the care that they need. But some of our patients are not getting the care that they need and deserve. And so we're here today to partner with government to implement solutions. And we brought 3 practical, implementable solutions that will make a difference. You've heard Dr. Urbach talk about our surgical backlog, over 1 million surgical services. Those are the hip, knee, cataract, and hernia surgeries that patients are waiting for years for instead of months, and it impairs their function. It places an ill-placed mental health burden on them and their families, chronic pain, and just too long of a wait. And so we have a way to reduce that wait and get those patients the care. So we want to see that implemented. You heard Dr. Mastrogiacomo talk about doctor shortages and the documentation burden that is just unduly distracting us from the investment in the relationship that we want to build and trust, the relationship of trust with our patients. It's just chipped into every time we turn away from a patient and turn towards our computer screen. And yet it is what is required of us. And so we do what is required of us. We do all of these additional expectations on us, as well as care for our patients. But it is hampering us, and we want to do it better. So we have implementable solutions around the doctor shortage. We want to reduce the barriers to licensed internationally trained physicians. We want to decrease the documentation burden so we can show up and let doctors be doctors. Thank you so much also to Dr. Singh. We want a focused investment and strategy around palliative care in our communities. We know it's the right thing to do. We know that it would alleviate the strain on the healthcare system. We know it would alleviate the stress in the emergency departments. That's my clinical background, 20 years in the emergency department working shifts in a community hospital, and it can be stressful. But when we show up with solutions and say, these are the things that we want to implement, and I have heard it echoed, the alignment of priorities and goals here today. So I'm leaving heartened, really, at the end of this day to get to work and see this work done and to see a difference made. And I'll be proud to stand with the group of government, ministry officials, and physicians and made a difference for our patients. So thank you, everyone, for being a part of today. It's been, and it'll continue to be, I think, a really good day.
Thanks so much. But before we finish, I'd just like to welcome onto the stage Dr. Shamji, who is the Liberal Health Critic, to say a few words.
Good afternoon, everyone. My name is Adil Shamji. I'm a family and emergency physician. I'm also the MPP for Don Valley East, the Ontario Liberal Health Critic, and I'm a member of the Ontario Medical Association. I have a personal practice. Every few years, I go back and I look at documents and things that I've written that really animate my passion for why I do the things that I do. And I recently went back and I looked at the letter that I wrote when I applied for medical school. And I said, I want to be a doctor because I think the job of a physician is to cure often, relieve sometimes, and comfort always. But over the last few years, and particularly during the pandemic, that has been a harder and harder task. It's one of the fundamental reasons that I stepped forward to run for public office, because I want to make our province and our healthcare system better. And I know that that is why all of you are here as well. We want to make our healthcare system even better, even though it's getting harder and harder to do that. I'll tell you a story. Yesterday at about 3:30 p.m., Angela Morocco called me. Angela Morocco is the business manager in my emergency department, and she's a close friend. And she said, Adil, I really want to see you. It's been a little while, but I can't wake up at 9:30 in the morning to come for a meeting. Because she was starting a shift at 5 p.m. She knew she'd be working until 3 a.m., and she's tired. We're all tired. But the fact that all of you are here, after everything that we've been through for so long, is a testament to our underlying passion, our unyielding passion to make things better for our patients, for our healthcare system, and yes, of course, for ourselves as well. So thank you. Thank you for pushing. Thank you for fighting, because I know how hard it is to start the pandemic and say, I don't know if we have enough PPE, to be doing your thing and then all of a sudden be instructed to pivot to vaccinating. And then after pivoting to vaccinating, being told to pivot right back. We have a surgical backlog to catch up on. It's hard. And then that administrative burden and navigating all of those referrals over and over again. It's not easy. So thank you for being here, for your patience, and for always pushing. You know, I believe that all policy is health policy. That's one of the reasons I ran. Because if we want our patients to achieve their full physical, emotional, and social well-being, we have to address things like housing, education, climate change, and of course, healthcare as well. I promised Allan that I would be brief, so I'll just summarize by saying this. For this afternoon, I want to ask you to do what you do best. When a patient comes to see you, you get a history, a physical, you formulate a diagnosis, and you prescribe a treatment plan. When you meet with the MPPs today, communicate your diagnosis. Tell the history of your patients and prescribe a treatment plan. Tell us, tell the MPPs the change that our healthcare system and our province needs to see. And if you do that, I can promise you that while you fight out there, and I'll be there too, I'm still in clinical practice, but while you fight out there, I'll keep fighting over here, inside. We'll amplify each other's voices, and together we will make this healthcare system the best that it can be. So thank you very much for being here. Thank you for all that you do.
Thank you so much. That's inspiring. Thank you. Dr. Shamji, I would just like to thank you for that very inspiring few minutes of wisdom. Lastly, I just want to thank all of you for joining us today and for listening so thoughtfully to the solutions brought forward by Ontario doctors. Our advocacy efforts at Queen's Park today are just the beginning of our working with this government to make sure that we're delivering healthcare at a high level in this province of Ontario. And it's been an honor, and we have felt very, very welcomed to meet with everyone here at Queen's Park. So without further ado, I'd like to close our session. Thank you.